I'm Rob,
And I'm Mike.
and this is Let's Get Ethical.
All right, we're back in again. Rob, how you doing?
Good, Mike. How are you?
I'm great.
Excellent. I want to ask you, how is the weather in California?
Oh, it's gorgeous.
Excellent.
Um, I t-shirt, jeans or shorts, you choose, flip-flops. Yeah. Sunny,
I
scattered clouds here and there, nothing big. Oh, it's beautiful. It's been in the 70s.
I'm
Yeah.
so jealous. I'm so jealous. It's been, we've had a very snowy winter in the Northeast. As you and I, we always seem to talk about the weather at the start of every single one of our
We
episodes.
do.
And it would go without saying that to my fellow New Englanders or for my friends across the country, it has been yet another snowy week in the beautiful Northeast. But you know what? The days are getting longer. The nights are getting shorter. Better
Yeah, and to
times
our
are upon us.
and to our viewers in Australia and the UK,
Yes.
and up in Canada, I have no idea what your weather's like. I have dropped. You know what? Comment below and let us know
Yes.
because I'm
Yes.
curious what your weather's like.
Yes. We'd love to know.
Yeah, and thank you guys for all tuning in. Absolutely. Oh, and let's get to that really quick before I forget.
Let's
Right
not
before I
forget.
forget, if you guys have any um, comments, any requests, right? Email us, let's get ethicalpodcast@gmail.com. If you have requests for something that you've experienced, something that you'd like discussed, uh, hit us up. Definitely let us know. And make sure that you hit the like and subscribe button so that you are informed of every upcoming episode. And thank you all for tuning in. Did I forget anything, Rob?
No, but I want to thank you for pointing out to all our friends across the world that are joining us. They're checking out our shorts, they're checking out our podcast.
Oh, yeah.
We are super stoked that our message is starting to spread across the world.
Absolutely. It's awesome.
Yeah, and
And it's amazing.
speaking,
It's really amazing.
it is amazing. It's like who knew, right? Who knew?
Right.
And I
Totally. Who knew?
and I think that leads us into what I would think this is our special episode, I think, for us.
Hmm.
Let's Get Ethical, because we really wanted to take an episode and we wanted to kind of talk about our whys.
Yes.
Why we love what we do, why we're so passionate about ethics and morality, and why we wanted to start a podcast, and why the conversation is so important to us. And Mike, I'm going to point this up because I would be
Oh, look at you. That's
remiss
awesome.
if I didn't
Oh,
highlight that I'm sitting here with your copy of Beyond the Breath.
wow. Thank you so much.
Oh, you're very welcome. You're very welcome. And for those of you who do not know Dr. Michael Sheehan as well as I do and others do, by the way, he's an author. He is a TEDx speaker, and he gives an amazing, amazing talk on Beyond the Breath, which Michael really speaks to your why, but it isn't just your why about ethics. That
Yeah.
particular book and your TEDx and your and your sorry, not your podcast, your talk at conferences, it talks about the why behind not just becoming an RT, but when I think you really had that pivotal moment early on in your career that spoke so loudly to you as to why you knew you had chosen the right path to follow, and how to this day you are so still affected positively by that experience.
Yeah.
And it kind of leads me to, as we think about, why is ethics important? Because you're right, you're a subject matter expert on ethics. You are a subject matter expert in patient care. You're a subject matter expert on making sure that respiratory therapists are held accountable to doing the right thing.
Yes.
And that speaks a lot to ethics. And I'm wondering, Mike, if you could, tell our audience, why is ethics so important to you? Why does it resonate so strongly in your heart and in your being?
You know, I thank you, Rob. Thank you so much. All the kind words, and thank you for throwing my book up. How awesome was that? That was a surprise to me. I appreciate that. Thank you. Shameless plugs. I'll take them all. You know, it's a matter to me of from just ethics alone. It goes back. Um, it goes back to, for me personally, how I approach the bedside. When I walk
Mm,
in that room, what is my mindset? Am I there to do a job? Well, of course, we're all there to do a job, right? Um, but am I there just to clock in, give some treatments, write some numbers down, suction a patient, and walk out? No. That's where I get affected. Um, and when I walk in the patient's room, I don't and I used to, but I don't anymore. I used to look at it as patient care.
mm,
Well, we always think of patient care and we hear patient care, that's the job, right? The job is patient care, but it's also not at the same time to me. Um, when I walk in the room, I don't see a patient. I used to, but I don't see a patient. I see a family member.
mhm,
Um, because that is somebody's family member. And as my, I've been in the field for 30 years, as have you.
mhm.
And over those 30 years, I've transitioned in perspective. I've transformed in thought and my role in that moment, right? And role duty is part of ethics.
Yes.
And and I've come to realize that when I'm at that bedside, everything that I'm doing has, I don't know if this is the right way to say it, an ethical consequence,
Yeah,
positive or negative.
yeah,
If I fail to do something correctly, there's a potential negative consequence. And so it's of the utmost importance that me, as a healthcare professional at that patient's bedside, caring for this family member, do everything in my power to act responsibly, ethically, and with regards to beneficence and justice with that patient. And so that's where ethics became so personal to me. And it's actually been amplified, because for those of you who don't know me, the one thing that Rob didn't mention is that for the last 13 years, yeah, last 13 years now, oh, it might be 14, I don't know, 13 or 14 years, I've served as an expert witness on more than 26, 28 different medical malpractice cases, both for plaintiff and defense. And in reviewing these medical records and reviewing these cases and being deposed and giving that testimony, um, the ethical component of what we do has really been amplified to me personally. And I'm not here to stand on my soapbox and preach to everyone, but this is me personally. Um, we we potentially can make mistakes that cause harm. We can
yeah,
potentially make mistakes that kill and cause death. And that's really, Rob, that's really amplified it for me personally in over the last 13 or 14 years.
mhm,
My transformation as a bedside practitioner was complete well before that, but it's really come back to light, which is why I wanted to do more, which is why I wanted um, to spread our message, spread our profession to an audience like the TED audience that doesn't necessarily know what respiratory therapy is. Sorry about that, everybody. We had to cut. We had a little technical glitch. It wasn't a technical glitch. I'm lying. Somebody came to my door and my dog started barking. I was right at the end. You probably heard a little bit of my dog's barking before we cut. I was right at the end of what I was saying on my soapbox there. So sorry about that, everyone. We don't normally cut. We like to just have it go all the way through. But in this case, it was necessary. Sorry.
Well, so getting back, Mike, I think you did a really nice job of expressing personally why ethics means so much to you. I absolutely love how, and I imagine that I agree with you. Like there's taking care of the patient sometimes, or performing the tasks, right? Is a tasks,
Right.
but we need to look at it, and you made a good point, right? Everything we do in healthcare, and even in life, but especially in healthcare, potentially has consequence.
100%.
And I think about, the phrase "to err is human." And if you hear those words, how do you personally, thinking about ethics, how do we take that phrase and try to prevent, for example, making bad ethical decisions? Like what do you think when you hear that? And how do you go about, like, in your respiratory care and your healthcare practice, of trying to minimize making mistakes? Because we all make mistakes. We're human.
And that's a good question, right? So that's an amazing question. And let me start off my answer with what I tell students. Um, because as an educator, uh, trying to explain the importance of what we do, um, from that vantage point of I don't want to make a mistake. In those moments, I don't want to, and trying to explain that it's like your parents telling you don't touch the stove as a kid. You're still going to touch the stove,
Yeah.
until
Yep.
your friend at school says I touched the stove and it hurt, and you make a mental note right then to never touch the stove. It's that kind of a thing. I feel like I'm a parent telling my kids not to do something or to be careful, but I do try to illustrate it. Um, and I always use McDonald's and Starbucks. I say, look, if you work at Starbucks and you ruin somebody's coffee, you make another coffee.
Yeah.
If you're working at McDonald's and a burger falls on the floor, you just make another burger.
Yeah.
To err is to be human. Yes, right? To err
Yeah.
is to be human. I get it. But if you make a mistake that is potentially life-threatening at the bedside, you're not making another one of those. And that's the point I try to illustrate. And and there's no easy answer really to your question of how do we do that? The only way we can do it is because we're still going to make mistakes, but are they going to be the life and death mistakes, or are they going to be the simple non-threatening mistakes? Let's make
Right.
them this. Let's make them those simple non-threatening mistakes. And understanding the gravity to me of being at that bedside in that moment, and the consequence or potential consequences to a certain action or to the lack of another action.
Mhm.
Understanding that gravity, and really caring about what we're doing in that moment is really one of the best ways to minimize the risk of making that kind of mistake.
I agree. I agree.
Can we, Rob? Oh, it's rhetorical. I'll ask you anyway. Can we eliminate the potential? No.
To make mistakes? No.
Yeah.
No.
But
No.
what we can do is we can avoid those gross mistakes. We can avoid those mistakes that are what the law would call negligence.
Yeah. I was just gonna ask you about that.
Mhm.
I was gonna ask you, what are the thinking about back, like, I think you and I will be the first to admit, if we made minimal, small, little errors. Yeah.
Yeah.
Yeah, of course we have. The difference is recognizing that small, minimal error versus purposeful gross neglect. And, Mike, how do you personally, especially with, given that you're a expert witness, how do you sometimes wrap your head around when you're reviewing a case and you look at something and say, like, how could somebody have done this? Like, how could they break the ethical bonds of society and have created, like, such malfeasance and just been so grossly inept? How do you grapple with that in your head? Because I would want to throw things against the wall personally.
Yeah, I do too these days. But I you have to remember that you were once that person. We were all a student. We were all a new grad. We were all green, and we all made those mistakes. Um, it's it's a matter of cutting corners, and I'll say it, laziness.
Mhm.
If you've been in the field for 15 years, 10 years, 5 years, and you haven't come to the understanding that what I'm doing here in this moment is so vital. And as I was just talking about it the other day with my students, something as simple as giving a neb treatment up on fourth floor, we think of it, as leaders, you and I, as leaders, you're a
Mhm.
manager, I'm an educator. We look at that and we think, oh man, that's so simple. You go in, you do these things, and procedurally, it's easy
Yes.
compared to a lot of the other things that we do. Um, but walking into the room, the view from the room, the patient expression, the verbal, nonverbal cues that we get, um, the IV bags that are hanging, the medications that are hanging. Where is their IV? Do they have a shunt in place? What's their most recent blood pressure? Do they have a history? Are they NPO? Right? All of these little tiny things make it more complicated if you focus on them. And the thing is, we kind of need to focus on them.
Well, yeah, because people's lives are at stake, right?
Absolutely. Even up on fourth floor, giving that treatment. I told my students, and I'm sure it came across as kind of arrogant. I didn't mean it to, but I told my students yesterday, um, there was a different me 20 years ago than there is me now, right? 20 years ago, if you put me in the NICU, I'll blow you away. If you put me in ICU, I blow you away. Put me in ER, I'll blow you away. Put me up on fourth floor, I'll take care of those patients. They'll be good. But listen to what I said. I changed my response
Mhm.
to up on fourth floor. And I told them today, if you watch me in the NICU, I'll blow you away. I will care for those kids like nobody else. If you put me in ICU, same thing. ER, same thing. But now if you put me on fourth floor, I'll blow you away. Because I walk into that room and I realize that this patient may have 3 days ago been in ICU. Even though they're in a different level of quote acuity in the hospital, it doesn't mean that I relax my care. It doesn't mean that I relax my approach to that patient. I still owe them the same duty that I owed them when they were in ICU, right? I still owe them the same duty as when they were in ER. I do. And we have to remember that. We get and I also told them, I told them this, and I'll say it here because I do believe this. And you tell me as a manager if you disagree. If because this definitely relates to you more than it does to me. If as a manager you have a therapist who doesn't want to go to ICU or ER, but really just loves going to fourth floor, loves going to the
Mhm.
floors and doing floor care, put them on the floors. Don't make them go to ICU.
I am 100% with you, and I have therapists like that,
Yeah,
and you know what? They're not comfortable anymore. Was there a time when they were rock solid in those environments? And over the years, they've allowed kind of the younger, more energetic RTs to get into those heavier critical care assignments. But these therapists are so rock solid. They are so thorough,
right.
right, at noticing the finite little changes in their patients. I wouldn't want them anywhere else, right?
Exactly.
Yep,
Exactly.
wouldn't want them anywhere else.
And a therapist, and if you have the option, and we have to, I guess I should have prefaced that. If you have the option, if you have that, and then you have a therapist who loves ER, do what you can to get that therapist in ER. Does that therapist need to rotate to the floors to remember that there is that importance there as well? Yes. But I really believe that you put them where they care the most, and they're gonna do the
Mhm.
best job.
Mhm.
Because I understand, I really do understand that not every bedside therapist is gonna approach it the way that I just explained I approach it. I don't care where you put me in the hospital. I'm going to care for that patient. I'm gonna find a reason to need to be in that room. I'm gonna try and find the little minutia that makes my care just a level better, regardless of where I'm at. And you know what's interesting? It just popped in my head. I was working. This was back in 2007, and I was working one 2 to 10:30 p.m. shift, and I had just started at this hospital. But I'd been in education, so I knew everybody at this hospital, and so they were kind of just showing me that so I went to a room with a on it was a third or fourth floor room, regular floor care, and I went in there with a therapist who was assigned to the floor, and we got called up, or she got called up, and so I went up with her, and we walked into the patient's room, and it was her patient, so I let her assess the patient. She assessed the patient, and she looked at me, and you have to remember that I said I'd been in education at that point for about 5 years. I'd been
Sure.
in
Yeah.
education. And, and so I didn't do a whole lot of bedside care, but I was working there, so I was doing some bedside care. And she looked at me and she said, "This patient's refractory hypoxemic. They need to go to ICU."
Wow.
And if I'm being completely honest, in that moment, I had to stop and remember what refractory hypoxemia was, because I'd never heard anybody in the hospital care to the point where they thought, "Oh, I need to say this and document it." It threw me off. It's
Yeah.
not that I
Yeah.
wouldn't notice it, it's that at that point, I was like, "Oh my gosh, she cares.
That's
She's
awesome.
she's another level, that other level of care." And
Yes.
it only takes a little bit. It only takes, it doesn't take a whole lot. And I was talking to my students also. I know I'm totally monopolizing time, and I apologize. I was talking to my students also. This was all yesterday. I was talking to my students yesterday, and I was talking to them about the time it takes us to do a therapy, right?
Mhm.
Check a vent, give a neb, suction a patient, do CPT, that kind of stuff. Um, and I was explaining to them, I used to live in New Jersey, and southern New Jersey, and the hospital I worked at, this was back before diagnosis related groups, right? So we're all DRG based, and it was all about revenue. And I had probably 50 Q4 round the clock treatments that for some reason they didn't believe in QID or Q4 while awake and Q4 PRN. They didn't believe in that. They wanted them woken up at 3.
We've all
Um,
been there.
yeah, and but I had 50, and I had ER, and we had just 2 or 3 codes come in ER, and I missed a round of treatments. I got written up, right? But what I learned at this hospital
Mhm.
is that, and it wasn't uncommon for if you were in ICU to have 17 vents.
Yeah.
And then I moved to Southern California, and I started working at Sharp Mary Birch, and I would float over to Sharp Memorial. And I remember one day, it was I was still on orientation, so I was kind of orientating in both places. So it was early on, but I had just moved from New Jersey, and I had 4 vents. And at Sharp Memorial, at least at that time, if you had more than 3, they were checking on you constantly. And I remember I was in MICU, and I had my 4 events, and I was just in ICU doing my thing, and I had all the TVs to whatever channel I wanted to watch. Every time the supervisor came in to see if I needed help because I had 4 vents and they weren't used to that, I was always sitting. And I just after the second or third time he came in, I recognized it. I was sitting there watching TV. I was either in a patient's room, right, who had a vent, and I was just kind of doing some stuff, watching TV, or I was at the nurse's station watching my 4 vents, but paying it. I was sitting, and it occurred to me that time management is a big deal. Um,
Sure.
this was back
Absolutely.
in 2000. Oh gosh, 2001. Um, and I had learned such good time management because in New Jersey, I was constantly running. That now the care that these patients were receiving from me was bar none because I had all the time and I had 4 vents. I had gone from 17 vents Q2 checks
Yep.
to 4 vents Q2 checks. The amount of stuff I could get done was just blowing these people away. They were shocked that every time they came in, I was done. Or I was just, it was almost like, when you putt, I call it putt putting, you putt around the yard. You're like, I'm going to go do the yard. And so you mow and then you edge and then you pull a weed here and there. And then you kind of replace the lights on the trees and you know what I mean? And you just
Yep.
kind of spend some
Yep.
time putting around.
Yeah.
But I had built such good time management skills in New Jersey that when I came to Sharp, the amount of things that I could get done was it seemed incredible to some of them. And not to toot my own horn, these people wouldn't even remember. Um, but I just remember thinking to myself in that moment, I'm like, this guy, every time he walks in, I'm sitting. I'm like, maybe I should stand up and lean. It was that kind of a thing.
Let me ask you a question because I want you to tie that into something. In
Mhm.
that moment, well, thinking back about that experience now, tell me how you feel now about that ethically versus did you even consider anything ethical at that time frame?
In New Jersey.
Yeah.
Yeah, I knew what we were doing was uh, inappropriate.
Mhm.
Um, I was working night shift, and we had a 4-floor hospital, a something like a 20-bed ICU. They had just redone the ER, and I lived in an area in New Jersey, southern New Jersey, that was very touristy. So in the winter, you got all the CHF, COPD patients coming in the ER, and for some reason they always came in at 5 in the morning. Um, and in the summer, you had everybody who came down from Philadelphia and forgot their meds. And so
Yeah.
the ER was busy kind of year round. We had lulls, but it wasn't like, those of you who live in a Arizona, Texas, or maybe not so much Texas, but Southern California, ERs in the summer can get really slow because it's warm, it's dry, specifically Arizona, Southern California. We don't have those we don't have those extrinsic asthmatics like you get on the East Coast. It's quite a bit different in Southern California, at least that I've noticed, in my opinion. And yeah, I knew it was inappropriate, uh, but I also knew I was getting written up. I got written up repeatedly because I had to triage a set of treatments because I had a code in ER and
Mhm.
couldn't call on the ICU therapist because they had 17 vents. And on top of their 17 vents, they had the telemetry unit, which had another 25 Q4s. That was them.
Yeah.
And then on top of that, I had 50 Q4s and a hop in ER. But at the time, I had only been in the field for 4 or 5 years. I didn't know enough. I knew enough, and I was still learning about ethics. Right, ethics was introduced to me not in school, but in Tennessee. When I worked in Tennessee, I was about 2 years in respiratory, and ethics was introduced to me, and I had no idea ethics had any part in healthcare at all. Nobody ever taught me ethics. Um, so I kind of had to learn it on my own and realize that, oh, this is, instead of unethical, this is inappropriate. This is
Mhm.
unacceptable. Um, so yeah, I mean, but it was really, I guess, amplified again when I moved back to Southern California and worked at a hospital that really, the hospital itself cared about the patients,
Yeah.
cared about what we were doing, and cared about outcomes. Um, it was the contrast between the two was really amazing.
Do you think, Mike, that, um what's the difference in your opinion? Do you think, like, in your opinion, how does ethics and instinct play together? And do you think ethics and instinct play together, or do you think, in your opinion, What do you teach your students about the difference between ethics and instinct?
Um, that's an interesting question. I don't know that I have thought about the difference between ethics and instinct, but now openly and or lectured upon it. But now that you say that, um, they have to be related.
Let me put the question a little differently.
Okay.
What if I said, how do you feel on the difference between should I do this, not just can I do this?
Oh, um, that's a good question too, because I am an out of the box thinker. Um, and and the question to me, it's not should I do this? It's what should be done. A
Mhm.
little bit,
Yep,
I think of it a little bit
yep,
differently.
yep,
Um, it's not a matter of should I do this or should I be doing this or can I do this? It's a matter of what should be done. What needs to happen here? How am I going to get this patient from here to here?
yes,
Is what I'm doing appropriate?
yes.
Um, and even if it is there something else I could be doing that would be better?
Mhm.
Right? But
Yeah,
necessary.
sometimes our
Yeah.
instinctual, so for example, we might think, and we do often as humans, we think very instinctually, but do you agree that when we have to make ethical choices or ethical decisions that we back away from that instinctiveness to pause, to say, to your point, like we were talking about, should I do this? Can I do this? What's the right course of action to take?
Mhm. I think ethics, like everything else we do in healthcare, needs to become a muscle memory.
Yes.
Um, so that in those times, the instinct is an ethical instinct. Does that make sense?
Yes, 100%.
I believe that that's just like everything else is instinct. You have a patient who starts to Brady or starts to DSAT, is vageling down. What do? You don't have to think necessarily what to do. You increase the FI2, or if it doesn't help, grab the bag, give them some breaths. You know what I mean? Um, those types of things become a second nature for us. Almost, what pops into my head is driving a
Yeah.
car.
Yeah. Yeah.
Driving a car. How many times, Rob, do you drive from home to work or vice versa, get home and don't even really remember the drive?
More times than I probably want to admit on here.
Right. Especially if you're on the phone or something. And it's
Yeah.
not that you're being unsafe, it's that instinctually you know what to do. Red light, stop, green light, go, yellow light, go very fast. Now, for
Yeah.
anybody who doesn't understand that reference, that's from the movie Starman, which is back in the 80s. But no, seriously, red light, stop, green light, go. You see that, you know what to do. You don't have to stop and go, wait, what do I do here?
Yeah.
And that's what I mean by instinct. So if we ingrain and we marry ethics into our decision-making process becomes an ethical one.
Mhm.
But that's what I have really tried hard to do and try to instill in the students, so that when they go and they practice, even as students at a clinical site, they're seeing these things and they're remembering these things, because at first you have to force it. And what I mean by force it is you have to remember it and go, oh yeah, this fits here.
Mhm.
And every time you have to go, wait, this fits here. You have to make it a purposeful thing. And then eventually you don't have to do it anymore. You just find that you've fit it there.
Yeah.
Right. And
100%.
and so we have to do, and we do that with everything in life. We just don't realize it. We don't think about it.
Right.
Um,
Right.
everything, again, driving is a great thing. Southern California, rolling stops, yellow lights. Um, how we approach that situation, we instinctually think through a process. And everybody's a little bit different with their process, but it's all kind of we've intertwined them, and we've ingrained that in our thought process, in our reactivity, in our reactions. What do you think?
I so I agree. I think there is a, um, there is I think one of the things about, ethics that's really important to me is I believe it kind of validates our intuitions, and I think it's one of the things
Mhm.
that you and I don't always talk about on here yet, but we talk a lot about intuitions and validating
Yeah.
our intuitions, right? And that's kind of what I'm talking about, is that what's the difference between right and wrong? And talking about ethics gives us those it gives those feelings kind of a venue, because we're human beings and we have feelings and we drive a lot of those feelings. But ethics kind of gives us a chance to examine and defend or refine those 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 intuitions, right? You talk about the intuition of the patient Brady's, we know what to do, and it's that second nature of knowing what to do. It's that experience
Right.
where I think ethics starts to cross over into things, and I think you've probably been in just as many situations as I have, is I now might pause and say, "Wait a minute, this patient is decompensating. What were their wishes? Are they a do not resuscitate? Are they a do
Mhm.
not intubate?" And if we start doing these things, are we validate are we sorry, not validating, are we disrespecting that
Right.
person's right to
To
their
autonomy. Yeah.
decision, right?
Mhm.
Just
Yeah.
because we can do something doesn't mean we should do something. And that's
Right.
where for me, I know that's that human capacity, right? Not just because I can do something, should we do something? And I think those feelings are both right. They are distinctly human. And the more that we talk about ethics, the more we learn to practice ethically, the more I think that we sometimes take a step back and we pause. And to our students, right, and our new respiratory therapists, new upcoming respiratory therapists, we don't expect you to understand all this or to grasp all this, because when we start thinking about the ethical decision making process, when Mike and I talk about, some of the cases we've reviewed are really mind blowing. They take an immense amount of emotion from us to talk about those,
Right.
because we've refined our focus so heavily on ethics. I mean, I'll be the first to say, right, was there a time when we have to save everybody, right? Oh my God, I'm an RT and I'm a
Yeah.
new RT, and I so respect the sanctity of life that I feel we need to do everything for every person all the time. I don't I don't look at it that way anymore. And I think some of that is you and I have seen, and I knew that we both have seen sometimes in healthcare, and it's inadvertent, we further suffering. Not because we purposefully wanna do it, but because as humans, it can be very difficult to have difficult conversations with the loved one of that person in the bed when you can see the grief on their face and the hope they're holding out to, and how tightly they grip your hand when you come in and have a conversation and
Mhm.
they ask you, "Can they hear me?" And you say, "I think that they can hear you. They recognize your voice, and I want you to tell them you're here."
Right.
Now, I think in my heart of hearts, is that the ethical right thing to say? 100%. And we've had this conversation
Mhm.
that sometimes
Yeah.
we're not the ones to say somebody shouldn't feel some way or somebody shouldn't feel some way. But ethics has real stakes to it, right? It's not abstract philosophy. It bleeds, and you and I talk about this, right? Ethics bleeds into our laws and our politics and our relationships and our daily choices. Those are like the four pillars right there.
Right.
Right? Those are the four pillars that we go and we talk about all the time. And there can be an urgency to ethics that I've really come to appreciate when somebody says, "Well, yeah, they're not going to survive this illness, but we'll intubate them just so the family can get here."
Mhm.
And for me, I want to stop for a second and I want to say, but wait, if we put the tube in, now we're adding an extra burden to the patient's family because
Right.
how are they going to feel once they come in and see their loved one? Because we all know that when somebody has the tube holder in the tube, they don't look the same. And now we're adding a very complex ethical decision on top of the grief that they were already
Mhm. Yeah.
experiencing.
And are they gonna accidentally be filled with hope?
Yeah, yeah,
That's
yeah,
another
right,
thing that
because
pops into my head when you say that. Family and I it anybody who's in healthcare who has family who isn't,
Mhm,
um, has heard a family member discuss a medical procedure or an encounter with a doctor at an appointment, and it becomes, "Oh, well, they put mom on blah, 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 and they did this." And as a healthcare provider, and I've just had this recently, and as a healthcare provider, as somebody who actually knows about what was actually it was a respiratory illness going on, um, in my mind, I thought, "No, that's not what happened." That's not what happened at
right,
all.
right,
But that's their perspective
yeah,
because they don't have the knowledge. They don't have the training. They don't have those things. And if I can address go back to the instinct thing, because
mhm,
what something you said is really interesting to me. Um, I think I think there's instinct, that which we're born with. You know, somebody scares you, you jump and go ah,
yeah, yeah,
right. And then there's trained instincts, responses that we train ourselves to do. And you talked about one that I think needs to be highlighted. And it's important because I do it as well. I did not used to do it, but I do it now. Um, and that's the taking a step back.
yes,
That can be again that muscle memory, right? In that moment where we want to go all in, we know we can, but we don't know if we should. And
yes,
the instinct is to pause for just a split second and consider. And so that muscle memory is something that I think, and going back to your addressing new therapists and students in this conversation, that's something that they won't necessarily have right off the bat. It's something that you have
agreed,
to learn as you kind of go. And it's not something we can teach in the classroom. It's
right,
something we discuss in the classroom, but the I'll say reaction. The reaction is something that it has to be learned and trained
mhm,
over time. And because I have the same type of thing, and I sadly I have a story. I apologize. Um, and the story's in my book. Uh, and when I was working in Tennessee, when I realized ethics played a role, we had a 95-year-old patient who came in ER one night, and I was assigned to ER. And she came in cardiac arrest, and they brought her in, and I'll spare all the details. Read the book. They brought her over. We put her over. We brought her over. There it is. We brought her over onto our gurney. I checked for a pulse. She didn't have one, and we instinctively took over CPR because that's what we do. Um, the ER doc saw this and stopped us. He said, "Wait, stop. Oh, check for a pulse again. Hold bagging, hold compression. Check again." And so I did, and I let him know that there's no pulse. And we fully expected as a group continue CPR.
yeah,
But
yeah,
his response was, "Okay, we're going to call it. We're done." And this confused me. And he must have noticed because he explained it. He said just to the whole group, he said, "Look, guys, this woman's 95 years old. She just passed as peacefully as she's ever going to. Do you really want to bring her back and send her to ICU for a couple weeks? She's probably going to
right,
code again. She's going to suffer, and she's probably still going to pass. That's unethical. I won't do that." And he said that. He said, "That's unethical. I won't do that. We're going to let her go peacefully." And that was the moment that I realized ethics played a role in respiratory care and in healthcare.
yes,
I never considered that. My job wasn't that. My job was CPR, right? Intubate, ventilate, save this life, right? Oxygenate, ventilate, that's it. I hadn't considered that my goal or my job, my real role was to care. And that there's a huge difference
Compassion,
between.
right? We talk a
Yeah,
lot about you
absolutely.
say the word I love you talk about compassion a lot,
Yes,
and right, and I think this is exactly where to be ethical is to be compassionate,
100%,
right?
100%. It
Yep.
starts there and it kinda ends there. If
Yes.
you are compassionate, if you are empathetic, then you are going to care
Yes.
about not just what you're doing, but what you're not doing, what you could do, or what you should do, right?
Yes.
And
Yes.
should not do. You are gonna think about those things a little bit more, even if it's just a little bit. You're gonna consider something else, and you're gonna consider in that moment, is what we're doing correct? Because that's really what you're getting at is with the should we do it versus can we do it?
Yep.
We shouldn't always be doing it, right? And again, going back to my story, if as to the audience, if you guys, whether you agree or disagree with that doctor's decision, that's not the point. Um, you could argue anything, I guess, in that moment, and you wouldn't be wrong. Um, but
Go ahead.
with that,
No, finish your thought, and I'm gonna jump on what you just said as soon
okay,
as you
perfect,
finish that thought.
perfect. Whether you agree with that doctor's decision is not the point. Uh, the point is that he did make an ethical decision about the patient that wasn't in line with what we could do. But from an ethical standpoint, his decision was what he felt we should do for the patient.
Yeah.
And that statement kind of encompasses what we're talking about.
Yeah, 100%. The point I wanted to make, and I'm glad you said that, was that many ethical debates are not generally right. They go unresolved
Yes.
because there isn't a framework. If you're really speaking to ethics and you're really taking the time to have a solid conversation, ethics debates are not always easily. They don't get settled, and that's okay. And we know that smart, thoughtful people, right? They've
Mhm.
debated this stuff for millennia, right? You and I can both go back to all sorts of philosophers,
Right.
which means that there's really always something, I think, fresh to explore. And no one is fully wrong if they engage in the conversation. To your point, and I've been in the same situation where the patient comes in
Mhm.
and the doctor says, okay, stop. I experienced that once. I was working at a community hospital. We had heard there was a pickup truck that had we didn't know how many kids in the back, but we did know that EMS was bringing in a child in full cardiac arrest.
Oh,
We
wow.
didn't know how many injured children were coming,
Mhm.
and the EMTs rolled through, and the doc said, "How long have we been without a pulse? We've been without a pulse for X amount of time." The doc said, "Stop." We stopped. And that was hard, right?
Yeah.
Because this is a child and we know, right? We've always known that we go and we go and we go and we go, we go. And
Mhm.
it took me a second to after the fact to realize we didn't know how many kids potentially had traumatic injuries were coming. And in the moment, the doctor made the best decision he could to
Mhm.
utilize the resources, right? We talk about this in ethics, the resources available. What if 7 more kids were coming?
Right.
We didn't know. But that was hard, right?
Yeah. Oh,
That's
yeah.
that those are not easy things to be in the moment, but I would never yell at that doctor or yell at anybody else because they made a decision. They made the best ethical decision given the information that they had in
Mhm.
the moment.
Yeah.
And I think
Right.
that's what makes for you and I know for me, that's one of the things that I think personally why ethics is so important to me. Also that they're deeply personal, but they're universal questions. I think that they really touches on who we are.
Yeah,
what
and
we
they
value,
apply
right?
to so many. They don't just apply to healthcare.
Right.
That's
Right.
that's the interesting thing.
Right.
When we talk about, and I think for me, I'll just speak for Rob here. I don't know if you actually agree with this or not, but for me, the reason I don't use the term bioethics is because it's just ethics.
Mm.
I don't care where it
Mhm.
is; it's still ethics,
Absolutely.
and it applies
Absolutely.
everywhere.
Absolutely.
So I don't feel appropriate singling out bioethics in healthcare. It's just ethics. And
Yes.
it's the same ethics I use with my kids, with my friends, with my students, with my boss, with my coworkers, with my dogs. It's all the same ethics. You know what I
The
mean?
same. It's all the same.
Yeah, it
Right?
all totally applies.
If you found a wallet on the side of the street, are you gonna pick up the wallet and drop it off at the police station and say, "Hey, I found this wallet in the street. Can you please return this to the owner?"
Depends on how much money it has.
Uh,
I'm just kidding. I'm just kidding.
I know you're just kidding.
Right,
But that's ethics,
100%.
right?
Yeah,
And
that's
while Mike and I talk a lot about medical ethics because, right, we're clinicians, etcetera, but
right.
ethics is this it's a bigger, larger, overarching factor in every single aspect of everything we do every single day in our lives, and it plays so much into everything, and I think too, Mike, that it bonds us socially, right? Would you agree with that? That if when we
It does.
share our moral values, we do it with others, and again, it's okay to have ethical debates, even if they're heated. You and I don't agree on things. You and I have had
A lot. Yeah.
disagree. Yeah, yeah. Um, and we don't act in a manner that is intimidating towards one another. We have mutual respect for one another, and I don't know that that always exists for whatever reason. Now we get into the ethics becomes this very hot topic, push button item that I think we just need. It's about having conversations with one another.
And I think one of the most important, and you touched on it for a second. I want to point it out. One of the most important things about ethics is understanding,
Yeah,
is making,
yeah.
trying to understand your point of view, not trying to agree with you, not trying to
Mhm.
force my ideology down your throat, not not allowing you to force yours down my throat, but to simply understand where you're coming from.
Yes.
That's a key component to ethical conversations. I don't have to agree with you to understand you. I can totally understand where your position is on something, what your perspective is, and I can respect that without ever agreeing.
Mhm.
And that's one of the things I think we've lost in all the conversations we have uh, these days, in the media and TV, those types of things,
Mhm.
is we've lost I disagree, you must be wrong.
Yeah,
And
yeah.
that's not it. That's not how ethics is.
Right.
We can both have different opinions and we can both be absolutely correct.
100%.
It's
100%.
all about perspective, and what we
Yes.
need to do is come into the middle and find that middle ground that we agree on. I was actually talking to a student the other day, and I was pointing out, I was, without taking sides, talking about pro-choice and pro-life and showing him the middle ground.
Yep.
And he was thrown off. He was completely thrown off at first until he saw it, and then once he saw that there's a point, there is some place where somebody who's pro-life and somebody's pro-choice, there's something they're going to agree on.
A
And
absolutely.
you
Absolutely.
start there and work your way back out.
Yep,
And that's the thing.
and then the same holds right, that same holds true with our ethical choices and
Mhm.
ethical decision
100%.
making and ethical conversations. We don't need to necessarily run to the polarizing ends. Why don't we
Right.
start with what we have in common and what we can both agree upon, and then maybe we go out from there, and again, I think when it comes to ethics, that's okay.
Absolutely.
So, Mike, let me ask you this question because we're kind of just chatting away today. That's the whole purpose of our podcast today was just to have a conversation. Why do you think you and I do this? Why do you think we love it so much? Why do you think we love it so much and are so passionate about it that we want to speak across the country to it, that we started a podcast called Let's Get Ethical? Why? Why are we doing this?
Well, what's interesting is we kind of talked about why ethics is important to me.
Hmm.
We haven't talked about why ethics is important to you. So what we're going to have to do is we're going to have to wrap this up shortly, and on our next episode, we're going to focus on Rob, and I'm going to get to interview Rob. So that's what we're going to do here.
I think I
Um,
like that.
yeah, that's what we're going to do. But I think quite simply, it's a matter of giving back and demonstrating. That's what Rob and I do. We demonstrate how you can disagree respectfully and still come to that point where you validate the other person's thoughts and opinion,
Hmm.
and they validate yours. And in the end, the person in the middle that we're coming to common ground on is, in this case, the patient, that
Yes.
family member that we're caring for. And
Yes.
while might have different approaches and different avenues to get there, we're going to get there.
Yes.
Right. And at the
100%.
core of that is respect. And
Respect.
Rob
Always.
and I respect each other, but it's not about Rob and I just respecting each other. It's about the fact that Rob and I understand that you have to respect the process, and you have to gain a little bit of knowledge on how the process works, and you have to be self-reflective, and you have to be open to learning new things. And I told my students this the other day, and I'll finish with this. It's part of critical thinking, and the
Yes.
only way, and I'm going to say it as though it's absolute 100%. You might want to argue it, and if you're out there and you want an argument, come on, we'll have the conversation. We won't have an argument, but we'll have a conversation about it. But I think um, I truly believe that. Now I lost my train of thought. Sorry, I said too many things at once. I truly believe that. Oh my gosh, Rob, I forgot. What was I saying?
I don't know. What do you truly believe, Mike?
No,
Spit out
what was I
something.
talking about before I drifted so much? Oh my goodness. Um, Shoot, I've lost my thought. Darn it.
That's all right. Start with another one.
No, I lost my thought.
All right.
And it was a good thought, darn it. If I remember it next time, we'll lead with that. But I can't
Okay.
believe I forgot my thought.
That's
It
all right.
was I was building up to it, and I'm sorry I let everybody down. I'm so sorry I let everybody down. But let's end with respect.
Let's
It's
end
it,
with
it's
let's
respecting it's
yes.
respecting the ethics that's involved more
Yes.
so than it is the person.
Yes. So, Mike, as we wrap up and before we outro ourselves out, I just want
Mhm.
to say that we have a couple of more exciting episodes coming.
We do.
We are also going to be at the Missouri Society for Respiratory Care before you know it.
Yep.
We're going to have a lot of fun there. We're going to do a little collaboration with our good friend Maddie Pavlichko from RT Sidebar.
Yep.
And we're going to be interviewing Dr. Aaron Light. I'm very excited about that. We're also going to be interviewing, I'm not going to say who, but just somebody from the Missouri Society of Respiratory Care. We are super
That episode will come out the very first day of that conference.
Yes, so be on the lookout for that. And then, right, you're going to fly back to Cali. I'm going to fly back to New Hampshire. And then we're going to meet in California the very next week
Yep.
at the CSRC, where we're going to bring more fun and exciting discussion on ethics. So I'm going to take us out. I want you to join us next time on Let's Get Ethical.